The first ADPKD guideline that came out earlier this year is really a step forward in helping synthesize and standardized care, I think, because a lot of ADPKD care has remained fragmented. And so, for the first time, to start off with, the nomenclature around ADPKD and what should be used has been clarified. And KDIGO recommends that in addition to ADPKD, where available, one incorporate the genetic mutation. So, for instance, if someone has a PKD1 mutation, they would be identified as having ADPKD PKD1. If someone has a more rare IFD140 mutation, it would be identified as ADPKD IFD140. And this is important because it not just gives you a diagnosis, but there is prognostic information that can be obtained. And as and when treatments that are more gene specific and mutation specific come forward, identifying these patients for clinical studies would also be easier. So I think that's the first thing they've clarified. The second is how to diagnose patients and the algorithm of using which imaging modality, for instance, ultrasound, which is most widely available worldwide. That is what has been recommended in addition to the criteria for making a diagnosis. And when there is ambiguity about criteria, when additional testing, such as genetic testing, needs to be considered. So I think this has opened up our understanding of when and how to interpret diagnostic tests, around which there historically has remained some confusion. The other big thing to come out of these guidelines is really for the first time since we've had disease modifying therapy for over 7 years now, the PKD guidelines provide guardrails about which patients to use it in, what the high risk criteria are, and also provide a framework for how to titrate the dose of the medication, adjust for side effects. And so overall, we see this as the first step really in the evolving landscape of PKD. And as more therapeutic options and diagnostics become available, I think these guidelines will evolve. So this is a first big step. So I think there would be at least three barriers that I can see. The first is the fact that most people are still unaware of how to get genetic testing. So once we educate the community, the research community, the clinical community about modalities of ordering genetic testing and accessing it both for the physician and the patient, I think we will surmount that first hurdle. The second thing is interpreting these genetic tests. Genetic tests are not always black and white. There's a lot of gray areas in between, especially with cystic diseases. Some of the genes may not be the more common ones we expect, and we might see certain variants of unknown significance or VUS. So ensuring that people have access to a genetic counselor or geneticists who they can refer complex cases to is critical because therein that essentially underpins how we interpret the risk of that patient and whether or not they qualify for certain treatments or trials. And I think the third thing is the fact that there are complexities involved in actually genotyping the PKD genes. Take the PKD1 gene, for example, and it is a difficult gene to identify all the mutations in, and we are still discovering new mutations every month, every year within this gene. So, despite patients having a negative genotype, it doesn't mean that they don't have PKD. It is probably more likely that we actually have not identified the specific mutation. And this can be because some of these mutations are private and in certain families, and most of the world doesn't yet know about it. So I think those are the three real things. One is education and access to genetic testing. Two is how you interpret the genetic testing. And three, the inherent barriers and challenges of actually doing the genotyping. So tolvaptan, as you rightly point out, is the first and currently only disease-modifying drug for PKD. And what that means is that it can actually change the course of disease. In this specific example, we're talking about two things. One is the total volume of the kidneys, so the size of the kidneys. And we know that the larger the kidneys are, the higher the risk of kidney disease progression. And tolvaptan actually slows the growth of these cysts. And by extension, it also decreases the rate of loss of kidney function. And so it was approved about 7 years ago. But now we also know that tolvaptan comes with its inherent risks and side effects. The downside of tolvaptan and a side effect of it is that it makes people urinate a lot. So people pee a lot, they get very thirsty, they have a dry mouth, they have to wake up multiple times at night. And so it becomes a question about whether or not it aligns with their quality of life and they are able to take tolvaptan. For instance, there are people whose jobs don't allow them very frequent toilet breaks, who can't get access to water all the time. And so that might be a limitation. The second and probably more serious thing that people are concerned about is the fact that tolvaptan can cause elevations in liver enzymes in about 5 to 6% of the patients. And these are independent of the dose and whether or not they have cysts in the liver, it doesn't matter. And so the FDA mandated a REMS strategy to identify the risk and mitigate it. And what that means is that everyone who starts tolvaptan has to have monthly labs done for their liver enzymes for the first 18 months. And following that, it is every 3 months for as long as they're on tolvaptan. And so these are the two biggest risks the biggest considerations, I would say, when starting and continuing someone on tolvaptan. Great question. We actually have several drugs. Some are being repurposed and some of them are new molecules. With regard to the drugs that can be repurposed, perhaps metformin is one of them. Metformin has historically been used to treat diabetes for several decades now and has a safety profile that is quite acceptable. And we have preliminary evidence that tolvaptan may also slow cyst growth and slow kidney function loss. And there is a large ongoing trial, multinational, out of Australia, Europe, and Asia, that is looking at this in PKD specifically. SGLT2 inhibitors have become a cornerstone of managing most forms of chronic kidney disease. And with regard to PKD, there was initially some concern that they may actually increase the levels of vasopressin, the one hormone that we're trying to suppress with tolvaptan. And so there are ongoing trials right now to prove its safety and efficacy. But emerging evidence from smaller studies internationally suggests that SGLT2s probably can be given to patients with PKD safely, but we're waiting on more evidence. Outside of this, I think there are at least three molecules that are probably of interest, and these include molecules that are microRNA 17 inhibitors that have shown in initial studies to slow cyst growth and increase polycystin 1 levels. So there's probably going to be a large trial upcoming later this year. There are also polycystin-1 correctors, and in healthy volunteers, this has shown to increase polycystin-1 levels, and so there's a trial that is planned for later this year as well. And then there are some monoclonal antibodies that are also being evaluated. So again, I think this is because PKD is not a single pathological process. There are multiple processes involved that lead to cyst formation and the growth of the cysts. And so targeting multiple pathways is key. Tolvaptan does that by blocking the action on the V2 receptor. And these new drugs really look to act on multiple different pathways. So hopefully there will come a time where we have the option of putting patients on one or more options or switching between options if one drug doesn't work. So this is quite an exciting time for PKD research, really. ARPKD is different because, as the name suggests, it is autosomal recessive, which means that people need two copies of the gene in order to actually manifest the disease. Unlike a DPKD, which is autosomal dominant, meaning you only need to inherit one copy of the mutation. And so ARPKD causes cysts to grow, and most likely it is diagnosed in children. It is, in fact, it is something that can be diagnosed in utero, so even before they're born. And it is most commonly caused by mutations in the PKHD1 gene. And so children have to get one allele from both parents. So their parents may be carriers, they may not manifest the disease, but the children can. And symptoms can be quite severe and it presents with a lot of cysts in children, high blood pressure, urinary tract infections, and loss of kidney function at a much earlier age, typically, than with ADPKD. And so, unlike tolvaptan, which is approved for the management of ADPKD, we yet don't have treatments for ARPKD. And so I think there is a lot of interest to try and understand the pathophysiology of ARPKD and target molecules that can help this really vulnerable population of children. I'm excited for about three things at least, and I'll stick to three. One is understanding the diagnosis and risk stratification. And by that, I mean that historically, until the evolution of total kidney volume as a risk stratifier and as a biomarker in clinical trials, we didn't really have a tool to understand whose kidney function may worsen over time. We have a good predictive tool in the total kidney volume now, but we're really digging deeper and looking at the number of cysts, the cyst to parenchymal ratio, and different radiological parameters that are giving us a more granular picture of what these kidneys look like. In addition, we're also using blood and urine biomarkers and proteomics to expand our understanding of what high risk is and what patients may respond to treatments. So in that sense, I think identifying this patient population who will probably be at most risk, most likely to derive a benefit, and therefore should be included in clinical trials, I think that's going to evolve. The second thing really is the multi-target approach towards treatment that we are using right now, that we expect to use as some of these other medications hopefully will get approved. So we're not just targeting one pathway, but we're really targeting multiple pathways in the pathological process. And the third is that we're actually using a lot of patient-reported outcomes. So not just kidney function decline, but really we're looking at what is the quality of life in these patients, what is the impact of current management strategies on pain and their psychological burden. Because unlike a lot of other kidney disease, polycystic kidney disease actually has physical symptoms, pain, bloating, blood in the urine, and it also has a lot of psychological burden that comes with having seen generations be affected. So as we take into consideration these patient-reported outcomes, I think our management of PKD is going to end up being more holistic. So those would probably be the three things that I'm really excited about with regard to how we're going to manage PKD patients moving forward.